capacities. So this audience of people interested in hypertension know that there are many patients that we share, that many of us see patients with diabetes who are hypertensive, and of course vice versa. The current prevalence by province is shown on this slide, and you can see that Ontario leads the pack. The other point to make is that if you look at the prevalence, it is, of course, highest in those patients who are the oldest. So as we get older, up to 20% of us will have type 2 diabetes. So I'm talking about a very common disease. In addition, the last of the triumvirate is hyperlipidemia, and if you look at population studies to see how many of our patients are achieving targets for blood pressure, lipids, and diabetes, there are the individual diseases, but unfortunately, in trying to get all three targets in our patients, we are still struggling in achieving the targets. So about 15 years ago, if I was giving this talk, I would have talked to you about insulin secretion, insulin resistance, and the mechanisms of diabetes. And what's happened in the last 10 years is that the number of classes of drugs has grown, the number of tissues involved in the management of diabetes has grown, and for the non-diabetic practitioner, it's hard to stay on top of all of the new developments. My choice today is to talk about one class of drugs that some of you may have been hearing about, and there is sort of an overtone of hypertension, so that was why I chose the particular class that I'm going to touch on. We refer to our guidelines. These are the evidence-based guidelines from the Canadian Diabetes Association that were last updated in 2013. And we say that in choosing therapy for our type 2 diabetics, we typically start with metformin, and then we individualize. And for many people, that is not giving them a clear algorithm that they can follow. And there are many reasons why we individualize. So the second part of the guidelines is this table, and you can see that there are many choices and many reasons that you might choose a particular class for your patient and not another. And those choices have to do with risks of hypoglycemia, they have to do with coverage, they have to do with efficacy for glycemic management, they have to do with weight. And recently, there's been more work with cardiovascular outcome trials for safety and efficacy, and I will touch on that. So the decision is not easy. So in talking about the SGLT2 class, this is a new class that talks about kidney function and the effect of the kidney on reabsorbing glucose. And in the typical normal person, we filter about 180 grams of glucose, and using the SGLT2 system, we reabsorb 90% of it, and there are some SGLT1 receptors as well that are responsible for reabsorbing 10% of the glucose. In patients with hyperglycemia, our diabetic subjects, we have an acceleration and a turn-off of that system. So they may filter even more than 180 grams of glucose, depending on their control, but the system is even more efficient at reabsorbing all that glucose. And we typically lose glucose in the urine if our blood sugar exceeds 10 on average. What happens with SGLT2 inhibition is that, in fact, when we lower the threshold, but in addition, we are able to lose much of the glucose that is in the system, in the plasma, throughout the day in a continuous fashion. So the net effect of that is that it is helpful for the A1C lowering or the glucose lowering. So one of our surrogate measures of how we're doing is, of course, the A1C. And this is an example of one of the agents, canagliflozin. They all end in this piece, gliflozin, and there are currently 7 of them in development, so you will hear many more of these agents coming on the market. There are 3 on the market in Canada. So you can see that the net effect, depending on what the patient is on, is about a 0.7 to 1% lowering of A1C. So the reason we prescribe these drugs in general is for glycemia management. The biggest side effect, adverse event reported, is genital mycotic infections. In women, 1 in 10, usually 1 episode in the first 12 weeks. In men, usually about 1 in 20 men. Easily treated, usually don't recur. If you look at the risk of hypoglycemia, these agents in and of themselves or combined with metformin have a low rate of hypoglycemia. However, if you combine them with insulin or a sulfonylurea, there is, of course, an increased rate. So you can see that there is very little hypoglycemia there, but it increases depending on the treatment that is additional. And in the management of diabetes, the paradigm is 1 drug, add a second drug, 3 drugs. Now we're 4 orals, then basal insulin. So we use every tool that we have in terms of managing patients. So this is a hypertension meeting, and these particular agents have what you might call value added. And the value added has to do with blood pressure lowering. So the blood pressure lowering is a significant added benefit. It's thought to be due to the osmotic diuresis that these agents cause. And I'll show you a slide shortly that'll tell you how much blood pressure reduction. In the obesity world, agents that increase heart rate may be a bad thing, as you probably all know. So whenever you change blood pressure, there's a question about heart rate. And I'll say now that there is no change in heart rate with these agents. And when you combine these agents in our patients, remember that the average diabetic is on 3.2 antihypertensives in Canada. So there are lots of other drugs that are on board. Should we be adjusting those agents, or is there a cautionary note with regards to using these agents when we first prescribe them? So we always advocate for RAS blockade in our diabetic patients, and these agents should not change that dictum. So if you look at, and I've got 2 agents noted on this slide, but these are not head-to-head comparisons, but rather it's an aggregate slide showing the dapagliflozin effect on blood pressure here and the canagliflozin here. And in general, they lower the blood pressure between 4 and 7 millimeters of mercury, depending on the study that you look at. So I would say that is a significant effect on blood pressure. So whenever you talk about blood pressure, we worry about the volume-related adverse events of dizziness, orthostatic hypotension causing falls. And I'm not showing the data today, but there is an increasing literature with these agents and their possible effects on bone. So you can imagine the scenario of an older person who's prescribed these agents first, who then has a dizzy or other episode, has a fall, and then fractures. So those have been reported, and you can see again that there may be some differences depending on who the patient is. So certainly older patients have more of the side effects of related to volume depletion, people who have a reduced eGFR, patients who are taking loop diuretics as part of their therapy. And again, on the right, I've put 2 agents for comparison, and you can see this canagliflozin data is from their cardiovascular outcome trial. So these are patients who have vascular disease, and that may account for more of the events that you're seeing, and that you're seeing not a young, well population, but more the older patient with cardiovascular disease or comorbidities. So significant volume effects that have to be borne in mind when you prescribe these medications. What happens to eGFR and electrolytes? Again, another, is it a volume-related change, and what is the usual data? So you can see that There is reduced efficacy of these agents when you prescribe them in people who have reduced eGFR. The product monograph says don't prescribe if you are below 60 mLs per second eGFR. If the eGFR drops below 60, you can prescribe a lower dose. And you can see that the glycemic efficacy is reduced in that population. What about the eGFR and electrolytes? This graph shows us that if you have a normal eGFR, there is a very small reduction in the eGFR that is maintained during the use, and once you stop the agent, the eGFR returns to normal. If you have someone who has low eGFR, you may see more of a drop, up to sort of 8 mils per second in someone who's taking the higher dose of canagliflozin. That's maintained, perhaps attenuated, and is reversed as time goes on. So if you're tracking eGFR, you may see a change depending on where the patient starts. I haven't shown the effect on potassium because it really hasn't borne out to be an important effect. So you do not have to measure potassium unless you have someone who has a high potassium already from RAS inhibition and you're particularly tracking their potassium. So if you followed the literature on these agents in the recent while, there have been a number of descriptions of diabetic ketoacidosis. And most of us think of DKA in the context of type 1 diabetes. But in fact, DKA can occur in any diabetic. It can occur in a type 2 diabetic who has a relative secretory defect. And we know as patients go longer in the disease, they may need insulin therapy because they have that secretory defect. And so there have been cases in people who were thought to be in retrospect type 1, but in fact, there are patients who are type 2 diabetics who've also been described to develop DKA. So if you look, and this is one of the publications, the citation is in Diabetes Care. It's now been published since this slide was made. You can see that there were 12 patients out of a total of 7,500 patients in the canagliflozin registration trial. So it's certainly not a common event, but it does happen. And in their cardiovascular outcome trial, the CANVAS trial, when they did an interim analysis, they found that there were 3 additional episodes of diabetic ketoacidosis. If you try and look across the patients reported to have diabetic ketoacidosis, are there any hints as to who these patients at risk might be? So looking at the background characteristics, you can see that there perhaps are more male patients reported with DKA. It's been reported more in Caucasian patients rather than Hispanic patients. Their A1C may be higher. Their BMI may be lower. So this is more an overweight patient with a BMI of 27 as opposed to an obese patient with a BMI of over 30. There doesn't seem to be a difference in terms of eGFR or duration. It may be more present in people who have a longer duration of diabetes. When you start an SGLT2, depending on your experience with the agent and the patient in front of you and their blood sugars, if you read the description of how they're started, there's often a decrease in insulin. And some of these episodes of DKA have been linked to reducing the insulin too much. We typically lower insulin by 10 to 20% in someone who's well controlled and who is on insulin, and we're starting an SGLT2. So there have been long dissertations as to, whether the stopping the insulin and then another occurrence of an intermittent illness, such as an infection or the flu, caused some precipitating factor to be the major determinant of that DKA. So in some patients, they were able to identify that precipitating factor of an infection or other illness, which Osmotic diuresis on top of an illness leads to more ketoacidosis signs and symptoms. There were other descriptions of where the blood sugar is, and I think for some of our patients, the education piece has to be around the fact that occasionally these patients who go on to develop ketoacidosis do not have markedly elevated blood sugars. So their blood sugars may be 12 millimolar, and for a type 2 diabetic, they've seen 12 millimolar, and it doesn't worry them. If they saw 25, they'd be concerned, and they'd seek medical attention. So I think as prescribers, we have to do a good job, and we have to bring our pharmacy colleagues into this discussion of, if you're unwell, stop the medication. You probably have to stop it for 48 to 72 hours pre-op. That's another risk time for our patients. And our patients have to be instructed that they have to test their urine for ketones if they're not doing well, and if they're continuing to have problems with their blood sugars, to seek medical attention. The blood sugar itself may not be the best predictor with these agents, and I think that's the part that makes the ketoacidosis tricky. So for the last couple of minutes, I would like to discuss one of the outcome trials that was reported approximately a month ago at the EASD. So in this era of modern cardiovascular outcome trials, TIMI-SAVOR, TCOS, EXAMINE, ELIXA, they've been safety trials powered to show safety, cardiovascular safety, duration about 2 to 3 years, and they've been very reassuring for those of us who prescribe these agents. So EMPA-REG was mandated by the FDA to show cardiovascular safety. About 7,000 patients. And there were 2 doses of empagliflozin, which is currently available recently in Canada and is the 3rd to market in Canada of the gliflozins. The 2 doses were 10 milligrams and 25 milligrams, and there was a placebo arm as well. It was pre-specified that they would have a MACE outcome and that the trial would continue until there was 690 events, or roughly 700 events. Who did they recruit? All of these modern trials are similar in terms of the patient population. Everyone had an event in this trial. They came from around the world. Their A1C was about 8%. They'd had diabetes longer than 10 years on average. 48% of them were on insulin, 75% on metformin. And as seen in the modern trials, they were extremely well managed for risk factors. So if you look at systolic blood pressure, 135 on 76, LDL around 2, and they had a pretty good eGFR, and they had a BMI of 30. So that's the kind of thing that we're seeing. The majority of these patients had an MI. There were 10% with heart failure. That's not the most of the modern trials. TCOS had 20%, TIMI-SAVOR had 15% if you're a heart failure tracker in clinical trials. So it was kind of perhaps an average number of heart failure patients. 80% of them were taking ACE or ARBs, and the rest, as you can see, and because many of them had had an event, a much higher percentage of beta blockers than might be seen in a regular diabetic practice. Statin use was 77%, and lots of aspirin use as well. So this was the systolic blood pressure. It dropped on average, and throughout these trials, the EMPA-10 and EMPA-25 were not different, so they were combined, and you'll see that on the graphs. There was a sustained blood pressure effect, less seen on the diastolic blood pressure, more on the systolic blood pressure. Here's an example of the heart rate, so it was not increased with that blood pressure change. But there was a hush in the room when this study was presented because there was such a dramatic difference in terms of cardiovascular death. So the MACE was reduced significantly, but it was driven to a large extent by the effect of the 38% reduction in cardiovascular death. And similarly, there was a 35% reduction in the hospitalizations for heart failure. So superiority as opposed to just cardiovascular safety. So, you know that expression, this has rocked my world? Well, it has, because it really has changed the paradigm. So now there's a tremendous amount of work that's going on in the cardiology world to explain these results, and I cannot explain them, and there's lots of speculation. There was nothing significant in terms of safety or adverse events that was unexpected, so there was an increase in genital infections. So when you look at some of the trials that have changed our practice, you could see that you need to treat 30 patients with simvastatin for 5.4 years to reduce a death, 56 patients with ramipril for 5 years to reduce a death, and 39 patients for 3 years with empagliflozin to prevent 1 cardiovascular death. So I think this has made a tremendous impact on the diabetes community in terms of what we will be prescribing. So in summary, SGLT2s are a new class of glycemic lowering medications that can be added to any therapy throughout the continuum of treating type 2 diabetes. We will get to this agent because our patients require multiple oral agents and/or insulin. I haven't discussed this, but combination pills, you know that in the hypertension world, do help for pill adherence and pill counts. And I think that despite what looks to be a very important class of medications, we are still individualizing therapy for each patient as it's required. I'm happy to answer any questions. Not a significant factor, and certainly in the cardiovascular outcome trial reported there was no difference in terms of that as an adverse event. Oh, I'm sorry. Upper respiratory tract infections are noted in the product monograph, and the question was, have I seen that in clinical practice? And not particularly. So I've been in rooms with cardiologists discussing the outcome of this trial, and I've heard, well, but I want to put forward a statement that was made in that context by a cardiologist who said, this may be a diabetes agent that's going to be part of risk factor management for diabetics. And so I didn't show, you know, because of time, I didn't show you the A1C, et cetera, but I mean, it may be that in the patients who have established vascular disease, this is the group that were studied, we need to kind of move this class of drugs up to the top as I'm thinking about this. Now, they don't work with people who have significant CKD, so there is that kind of overlap. We have agents that are not particularly good for heart failure, so the worst were TZDs. But insulin, I'm old enough to remember starting a very poorly controlled type 2 on insulin, shoving their sugars down and precipitating heart failure. So insulin is the oldest drug described for heart failure. So it is possible that we now actually have a good agent for use in patients with heart failure, and I think some of the deaths were heart failure deaths that were prevented. They weren't all heart failure deaths, but in the adjudication process, that may be one part of the reason there was such a benefit.
Any idea when this is going to be published?
It is published.
Oh, it is.
Yeah, so it went online, New England Journal of Medicine, so it's out. Now, not all of the sub-analyses, all the heart failure stuff is not there, just the top-line results.